Thank you, Dr. Mutamba, for that very kind introduction. I actually want to kind of set a disclaimer that this is my baby step in the digital world, expanding, having spent most of my time doing active case finding and finding cases door to door in communities around Kampala. So I focused on that a little bit, and then my interest started to evolve. And really what I present here is, I would say, is part of the first work that I have done in the mobile technologies, and as you can see, it's a pilot. So I'm really here to share about some of the preliminary findings. And I promised myself that this is going to be the first time that I make a research-related presentation without a single p-value and 95 confidence. So for those who have very highly ferocious appetite for p-values, 95% confidence intervals, I say no to that, because this is a pilot, and I want to really describe what we did, and we're trying to understand, can we really use mobile technologies, can we use digital technologies for improving patient outcomes? So that's the goal of why I'm talking to you today, sharing some of the preliminary results, and wanting to really hear from you, because half the time, maybe more than half the time, I'm not really here on the ground, so some of the things I might say might not even make sense, but that's why I really wanted to hear sort of some feedback from the people who are doing the work every day to test whether this is really feasible. It's one thing to show a small pilot, but yet it's another when people who are doing the work day to day see the results and you can kind of test them. So that is that's going to be my approach today. So this is my presentation outline. I won't read it all, but I want to kind of land at the point, once I make the conclusions, I'll land at the point where I'm hoping that this will stimulate some discussions about what the results really mean and how we can move into the future with the digital technologies. So this will not really be a presentation from me, the last bullet, but it will be kind of, that's where we'll kind of kick off and begin the discussion. So we all know this is, very basic information, especially for the audience that I'm talking to today. I didn't delve into much of the background, which I'm glad Winters has done a fantastic job going to it. But I was very interested in this graphic here, because it says World TB Day, and then it says TB everywhere. TB anywhere is TB everywhere. But to me, every day then is World TB Day, right? We celebrate World TB Day March the 24th. Is that March the 24th? Yeah, so, but if you think about how much devastation TB has caused, we should think about TB as every day being a World TB Day, and that should kind of drive us into fuller force, more acceleration in the things that we do. So that is the point where I put this here. But of course, we know that in 2014, the World Health Assembly endorsed the End TB strategy, with a vision of a world-free TB, a world free of TB, zero deaths, disease, and of course suffering due to TB, and of course the catastrophic costs, which some of you might have heard about, zero costs or no suffering from TB, no costs as associated with TB disease. And of course with the goal of ending the global TB epidemic by 2030. But even as Dr. Mutamba went through the statistics, obviously we haven't made a big dent for us to even begin to think that we'll make it at that mark, the goal that we're talking about, the 2035 goal. We know that TB is the leading infectious cause of death worldwide right now, and the things that we must tackle to achieve the end TBs, the goals of the NTB strategies, we think about the incidence and prevalence, of course the new cases, the prevalent cases, and the big focus has really been around the early case detection, and that's sort of where I spent most of my TB research career, thinking about how do we find those undetected cases. And so I went out everywhere in the communities, in the slums, trying to hunt down people who are not presenting at the health facilities. And so that is a very, very important thing to reduce the incidence and prevalence. And then, of course, we are worried about the deaths, which we now know about maybe over 1.5. I don't know the current statistic. This we can curb by early detection, of course, getting people into treatment, and of course, focusing on the HIV care, knowing who is affected the most when they have TB. It's the HIV co-infected. And of course, the timely and accurate diagnosis, treatment initiation, retention, and completion. Those are all things that we are focusing on to try and meet this goal, these big goals that have been set. And of course, the big elephant in the room right now, the MDR, XDR, TB, that has become a big challenge right now. But the thing is, we all know that TB is preventable, TB is curable. We have the medicines that cure it. At least 90% of the cases can be cured with existing first-line drugs. So high levels of adherence are needed, are required for us to achieve that cure, at least to benefit completely. So the WHO estimates that at least 30 to 50% of TB patients fail to complete their medications as prescribed, and of course when we talk about non-adherence, it's kind of many different definitions. So I stayed away from putting that percentage number. Some people will say up to 95% doses, 80, others say 85. So the literature kind of varies. I haven't seen one standardized number that we say, but the key point being that we need to ensure that patients complete all their doses. And of course, at minimum, have a very, very high completion or at least adherence. And we know that poor adherence may lead to any of these things that I've highlighted here: MDR, XDR, TB, complex and longer, more costly treatments, which has been estimated up to that amount, but I know those numbers are changing with the new drug developments and new improvements in drug access. We get low cure rates and then high mortality rates, of course, especially in the HIV co-infected and ongoing transmission. So to me, not that the other three bullets are not important, but I would put my money, if I had a small pot of money, I really want to reduce deaths. And I really want to ensure that there are no ongoing transmissions, because as long as we are reproducing one case every day from another TB case, then we can never stop an epidemic. So as we try to wrestle the TB epidemic down or to the ground, we really have to pay attention to what's causing the new cases, what's generating new cases every day. So that's the point why I highlight those two. So this is just really a summary of what is in the literature about what factors are associated. And this list obviously is not comprehensive, but I just highlight a few things and I try to categorize them in three categories here. When you think about the patient level factors, there are things that have been highlighted as age. Sometimes you see older individuals are less likely to adhere. And then of course, low education, low socioeconomic status. And that, of course, can be a mediator. May not be a direct factor, but could be a mediator of that. Forgetfulness, lack of social support, stigma, interpretation of illness and wellness. We know that when our patients finish the initial dose, the intensive phase, they feel okay and they are bouncing and they go back to work. They feel they are fine. So they're really interpreting their wellness and health as I'm cured. I don't need to continue another 4 months of treatment. So as you can see, there's medication-related factors, and I'm not going to read the entire list. You can read it for yourself, and I'm happy to share these slides. Jackie, if you can share those. So, but just so to make the point that you can think about adherence factors or factors that affect adherence in these three categories. There could be many more other categories that you could show this, but this is an easier way for me to think when I'm thinking about intervention. So that if you're intervening, you can think, how do I intervene at the patient level? How can I intervene at the medication level? How can I intervene at the health system level? So obviously, this part here is kind of, to me, the dicey one. The medication level, it's what we have, and you know how long medications take to develop, and they're in the pipeline for years and years. So before you get them out, it's going to take a while. But there are things you can intervene on this side, the patient side. There are things you can intervene on the health system side. So that's the point for this slide. So we know the current standard of care, of course, as my colleague has highlighted, directly observed therapy. It's a wonderful strategy that has been around for over 20 years. And it's done what it can do. Has it achieved some results? Yes, we have seen success stories in some areas. But that's not to say that it's an end-all be-all. We are going to just stick to an old method that has been around for 20 years because we haven't seen it making a huge dent in the epidemic. So established in 1995 to ensure adherence to treatment and patient support, of course. And so here I said DOT ideally. Of course. We know that it's not ideal. It's hard to deliver that ideal DOT. If it's given in its ideal form, I'm sure it would be perfect. It would be able to achieve the results that we want. But it's not offered, it's not delivered in an ideal way because we lack, many different things that can make it ideal. But we know that it involves face-to-face meetings between patients and health providers, and it's a designated person to meet with at the health facility, so workplace, home, or community. So again, just for typically non-TB. But we know that there are limitations to DOT. And here I kind of categorize them into two. And again, the list is not comprehensive, but to highlight the things that are really limitations for DOT. So we know that it's labor intensive. Studies have estimated up to 100 to 200 hours per patient on just the supervision time. We know that it's costly in terms of time, personnel, and of course transportation. And a recent study estimated about $4,200. Of course, context matters. Maybe it wouldn't cost that much in a Ugandan context, and about 130 hours just performing DOT to one patient. Disrupts workflow in the health system. If a patient comes and they need to be supervised, then you have to stop what you're doing and then go supervise them, then let them go and all that. So it leads to inefficiency. Administrative burdens to document daily adherence, of course, leading to inaccurate reporting and all those things, which most of you who are working in the health system have seen. And then on the patient side, it's more the inconvenience, the restricted mobility, the limited autonomy, and the high out-of-pocket costs, and impractical for, of course, most rural-based patients, and may compromise sometimes the patient privacy and may lead to stigma. And we've seen some studies that have shown patients expressing that they feel a little bit stigmatized when somebody has to come to their home every single time. And we saw that also kind of in the HIV world when people needed to be followed. So what's the solution after having kind of highlighted and reminded us about the problem? Is to, and this is just one of the solutions proposed that we know right now in the literature, is modernizing DOT with the use of the mobile technologies. So why mobile technologies? mHealth, which is defined by the WHO as just using any medical device to support healthcare, support either clinical or public health or medical practice, using mobile phones and all these other devices that we can use. And we know that there's rapid expansion worldwide. The number of phones right now exceeds the population of the world. That's what the International Technology Union, I think, has stipulated in their last report. We are 7 billion, right, population, and I think the number of phones is about 8 billion, thereabouts. So it's really as far outpaced even the population growth, meaning, of course, we can do the math. Most people here have two phones, right? So that's how that number goes, and it's even beyond the population. So this industry has been estimated or projected to grow, at least by 2018, to reach at least $10 billion US dollars, just the industry alone in growth. So there's a lot of growth in this industry. Everyone is kind of trying to latch onto this technology and trying to see how to leverage it and develop more products. So that's why the industry is really growing very fast. Of course, the TB patients and the health providers are living around these ICTs. They are living around the mHealth tools, and they are really using them anyway. So why not try to leverage some of what people have in their hands? So that's why that's the case for technology. So this is just to show you how much cell phone in Africa, cell phone use or cell phone ownership alone, in Africa alone. And this is all data, as you can see. I couldn't find a newer graphic. About 2014, you can see, but the whole point I want to make here is just see how steep the trajectory is. And it's only, I don't know where it will end, but at some point I think in Africa everyone, 100% will have phones. I don't know. Maybe it will be close to that. But this is something to think about in terms of technology in our hands providing more tools that we can take advantage of in Africa. So in 2017, when the WHO updated its treatment guidelines, most of you I'm sure have seen this report, they did make an endorsement, so to speak, which was a recommendation of video observed therapy. I highlight it in yellow here. saying that video observed therapy may replace VDOT when the video communication technology is available and it can be appropriately organized and operated by healthcare providers and patients. So they made these conditional recommendations, but based upon very, very low level of evidence. So what does that tell us as researchers? They went ahead and made the recommendation, but we still have to produce the evidence that really supports its sustainability, because once people don't find evidence, then they'll drop it off the radar. But as we produce more evidence, then it will stay. It will stand the test of time, and then we'll also be able to refine it as we go and improve the kinks and the holes that might exist. So that's interesting, and that kind of motivated me to kind of follow this path. And there's also this new handbook that came out about use of digital technologies to support tuberculosis medication adherence. Some of you might have already seen it. And in there, there's some basic questions that they point out. And I was very interested in these ones. There's a lot of information in that book. It's a small handbook, but there's this information here. It says, so you have to think about which application is best suited to your circumstances. So, and that motivated the search for understanding how the technologies work in the Ugandan context, the local context. So it's nice to hear that it works very well in the US, but does it work in our Ugandan context? What is the evidence for effectiveness? So as you can see, yes, WHO had almost zero evidence, very, very limited evidence for effectiveness. And then how do you implement it? So that's an implementation science question, and I know Dr. Killings Katamba is the implementation science guru in this room. So they ask, how do you implement it? So there's going to be a lot of implementation science questions around the technologies. And then who will pay? And that's really cost and cost effectiveness. So all those questions are really going to have to be answered if we are going to successfully implement the digital technologies. All right, so now shifting gears and focusing a little bit more on the video technology itself, which is the video observed therapy, VDOT. It's kind of a cool name, I like it. So it really is simple. It's a method of adherence monitoring that involves the patient submitting a video. So they will take a video that they've recorded of themselves taking the medicine, and they'll submit it on a daily basis to a health system. Then what the health system does, or the health provider does, is to watch that video to confirm or validate that the patient actually swallowed their medicine. So kind of it's a DOT, but in a virtual space. So it's remote dot. So there are two types, and I really shouldn't have made the distinction, but because these are now available on the market, there's the asynchronous and the synchronous type. The one that I'm going to focus on is going to be more the asynchronous one. The synchronous one has been used, so it's a real-time live streaming video chat or video conferencing where the patient takes the medicine. But the other one is a recorded video stored and then forwarded. So you can quickly see what the advantages would be even without me stating those. So I'll focus more on the synchronous one because that's the one I piloted in the work that I'm going to present. So here's a description of this asynchronous VDOT. You have an app on a smartphone. The patient logs in. They have their meds in front of them, right here. Then they get the phone, and then they're recording while they're swallowing the medicine. And once they're done, they'll hit submit, and then they submit, and the video is encrypted, and is stored, and then goes to a cloud server. The health provider on the other side does view it, opens, logs into the computer system, and watches all the videos that have been submitted by the patients, watches every single act of swallowing. So it relies on a cellular network, so you can actually take the video without internet or without Wi-Fi, but of course sending it will require that internet connection. So basically the person can be in a place where they have cellular network but they don't have internet, but then they are able to record their video. The video will sit on the phone, but the good thing is that once you hit submit, you can't open the video. You can't go back and open the video, tamper with it. So it locks itself and just waits at the point when you hit a place where you have internet connection, then it will submit itself automatically. So even the patient themselves, the patient cannot go back and try to see, oh, let me see what I did, let me try and adjust and take my pills better, or try to straighten my hair, things like that. The moment you hit submit, it's gone. It's sitting somewhere on the phone, but it's not accessible. So that's a kind of a safety feature. So the platform that I used for my study is a Sure Idea platform. It was developed in California by some folks at the University of California, San Diego. So really the steps are simple. So I show it just to tell you that it has been validated. It's HIPAA compliant. HIPAA compliance is just really the law stuff and making sure that the safety issues are taken care of. And then so those are the steps: smartphone, automate with some, upload the encrypted video and then send it to the health provider. The other thing that I forgot to mention though is that it's got also this SMS reminder. So let me just say something because it helps cover some gap. It sends a reminder prior to the swallowing of medicine. The patient will say, okay, I take my medicines at 6. So an hour before 6 a.m., a reminder will come. And then an hour after that, if the medicine or if the video has not hit the system, then it will send another reminder. And you can set up as many reminders as you want. You can customize it any way you want. And so you work with the patient to tell you what time and then facilitate or support them by sending some reminders. And then the reminders, there's also in the system you can customize by putting some messages, support messages, motivation messages, and all those things. If you're interested, I can go in detail of that later on. But that's the basic. The system is really, really very basic, easy to use and easy to manipulate. So on the side of the health provider, though, there's a dashboard. So the health provider logs in and is able to see every single video that was sent, and then is able to enter some information in terms of after watching the video. Is the video clear? Is there good visibility? Did you see all the pills being taken? And then you fill in that information. It's captured within the dashboard, and then you save it. And then, of course, the patient's demographics are also captured within the system. So all this is to say that the system is really doing most of the administrative work and capturing some of the information people put on paper, and you're sort of watching and putting those blue cards and ticking and making crosses, and then bringing it back and putting it in the register. So it's kind of capturing all that information for you in one place. So this is a conceptual framework that I kind of came up with as I began to think through the factors that we're trying to address. What is VDOT helping us address? Obviously, VDOT is not a silver bullet. It's not going to fix every single problem there is in terms of adherence. But this helped me to kind of pinpoint some of the things that at least VDOT can help us minimize or zero in on. And as you can see, the barriers to DOT on the health system side, again, I will not read each one of them, and then on the patient side. And then you can see how VDOT actually addresses some of those things on this side. So when VDOT is trying to eliminate some of the barriers and enhancing efficiency, both at the health system level, but also helping or supporting the patient in terms of the things that we identified as some of the factors that lead to non-adherence or poor adherence. So as you can see here, there's the daily texting, the SMS text reminders of medication, then the two follow-up SMS reminders hourly, and then the automated SMS prompt to report side effects, and then the follow-up call after side effects by the health provider. So the health provider takes the information that comes to the system and then acts on it by picking up the phone and calling the patient who has not sent a video, for example. So shifting a little bit now into what's done, what's known, what has been done with the current literature here. These are smaller studies, pilots that have been done mostly in the US. But the point of this slide is to show you that across the spectrum, across the board, these studies have demonstrated that you can achieve a high level of adherence when you use VDOT. Yes, the samples are small, and these were all pilots, but you can see done in different locations, you can see that at least they all hit the level 90 as percentage expected doses submitted, observed through VDOT. And then this I show you here just because I found it really interesting, because they also used it in Hurricane Harvey, which happened in Texas about, I think, a year ago, or 2 years ago. And then they gave people a VDOT app when people were scattering and they were being moved away from their houses at their locations because of the hurricane. But they had 61 TB patients, 30 with active and 31 with LTBI, and they all were monitored. At least 97% did not miss a single dose during the time of the hurricane. And hurricanes are, devastating, and people kind of scatter. They go everywhere. They go in homeless shelters. They go in camps, and some disappear. You don't know where they are, but you can see 97% did not miss any of their doses during that hurricane. So I bring that to make a point that patients were supported remotely by the healthcare providers while the disaster was taking place. So these are I'm going to highlight just a few papers. Of course, I can't go through all the literature, but these are the seminal papers that are out there right now about VDOT. This study was done in Vietnam. It's a pilot as well. And as you can see in summary, it was published in 2017. It was a prospective design with a sample of 40. And they only used VDOT, gave it to just patients. They didn't compare. They didn't have a comparison group. They followed up patients for 2 months, and they found a median expected doses observed by VDOT of about 88%. So the other study, this was done in California by the same individuals who developed the Shared Here platform. They did a quasi-experiment. And what they found was that, and then they had a comparison between in-person DOT and VDOT. And for VDOT, they found a 93% median fraction of expected doses compared to DOT that only had 66%. And of course, they also analyzed the cost of treatment for monitoring, and they found that the cost of treatment monitoring for VDOT was 46% cheaper than the DOT. So this is the most recent study that just came out in the Lancet, just recently in 2019. And they also, it's an RCT, it was a multi-center randomized trial of 22 clinics in UK. They randomized to VDOT and DOT, and the outcome was completion of at least more than 80% of the doses in the intensive phase. So they really focused on the intensive phase. And what they found was for VDOT, 70% of the individuals randomized to VDOT had completed 70% had completed 80% or more of their doses, whereas in in-person DOT, it performed so poorly. You can see, and in UK, I kind of didn't expect this. It kind of surprised me to see that only 31% within the intensive phase were able to complete their treatment. So again, this is much lower than the other results that I showed you, but it makes a case for VDOT. Okay, so that's enough for sort of the bigger picture, background, literature, and what's the current state of the evidence. So now I'll delve right into the actual pilot of the work that I did. And this, again, was motivated by the lack of published evidence on acceptability and feasibility of VDOT in Africa. I didn't find any study. And of course, the need to explore innovative ways to improve care and service delivery for TB patients, and then the rapid growth of cellular phones. So this tells us that we have a platform with which we can work on. It's one thing to say this is something new and different, but if there is no platform to carry it, there is no infrastructure, then we can't really take off. But there is a very ripe opportunity with a very rapidly expanding infrastructure that we can leverage and piggyback on and be able to make this happen. And so this is just some work that this is from my unpublished work. I'll show you a little bit. So I also wanted to collect preliminary data for a well-designed, adequately powered, randomized control trial to evaluate the efficacy of VDOT and DOT. So that's sort of where I'm going with a pilot, and then sort of build it up to a randomized control trial. So I show this. It's kind of weird to show you results here, but this also is part of the motivation. Because I did a preliminary kind of feasibility, trying to understand if we do VDOT, do people even have smartphones? Do they have phones? So I highlight this part here just to show you that this is kind of recent, because when I showed you the data from Pew Research, it said 65%. Remember the curve that had the trajectories, and Uganda had about 65% cell ownership in 2014? So in 2016, I surveyed patients within the clinic and asked them whether they owned phones and whether they owned smartphones. Because this was going to be carried on a smartphone, and everyone said, well, people don't have smartphones, and especially patients who didn't have smartphones. So I was trying to make a case for, can we really do it? And as you can see, this is the part I really wanted to focus on. So 96% of the patients we surveyed actually had phones. And then on the smartphone side, at least 38% did say they had smartphone only, and then these had both. They had smartphone and regular phone. So that's about 54%, right? Oh, no, it's 50, it came to 56%, I think, right? Am I doing the math correct? So that's 51, right? Yeah, so anyway, so then I asked about phone usage and all those things, but this was the point that kind of convinced me, because the rapid growth tells me if at 50% people have smartphones, within a few years it's going to really go really high, and we can do it. Okay, so here is the list of aims. I wanted to assess perceptions and perceptions and acceptability of VDOT among health providers, TB, and caregivers in Uganda, and then to determine the preliminary adherence level when using VDOT for TB treatment, and then to assess the technological, operational, and cost feasibility of VDOT. But for this presentation, because of time, I have so much data and there's so much details, I'm really going to focus on aim 2. That's what I'm going to present. And then the results for 1 and 3, I can always come back. Okay, so here is the flow chart. I'll kind of go through the eligibility, really through, as I walk you through the flow chart. So we screened about 68 patients, and we found that about 16 were not eligible. We had 52 that were eligible, and our eligibility criteria was 18 to 65, receiving treatment for drug-susceptible TB, and then having a cellular network at their residence. And of course, those who gave informed consent. So we enrolled the 52, trained them, and gave them an app. The app is actually free. It's a free app downloadable through the App Store. And then they put that on their phone. We actually assigned smartphones. So we were not going to eliminate people because they didn't have smartphones for purposes of equity. So we provided some smartphones, and actually starting out, we wanted to just focus on just giving people phones for standardization and all those things. But then as we went to the field, we started realizing that, we revised our protocol, and we said, no, I think it might be better to include more people than to just limit the sample by the fact that people will not have smartphones and they won't come. So then we revised our protocol and included people who came with their own smartphones. They bring their phone, they ask you, do you have a smartphone? Yes, and then we put the app for you. And then the next, you're ready to have the video DOT. So we had individuals, and I'll tell you how we kind of split. It's about a 50-50 split. We had 50 people, half the people with their smartphones, and then others received study smartphones. They assigned a PIN to access the app, and then they received a VDOT instruction packet, which kind of walked them through. We trained them, and then we gave them a packet to take home with some translation. Do this, do this, do this. So that when they get home, should they get stuck? We had some people who were first-time users of smartphones. So it was kind of a risk to give people phones, and I was kind of a little edgy about that, but it worked fine. So then we had 50, so we had 2 that withdrew. I can't remember what the reason was. I think one had a very sick child, and then the second one, I can't exactly remember, but they withdrew just really in the first week, so we kind of do not include them in our analysis. And then we have 50, so we followed those for as long as they were on treatment. We allowed people to enter the study not just at the beginning. If somebody was within at least 2 months, 2 to 3 months of treatment, we allowed them to join VDOT, just so we could observe really how are they able to use the VDOT. So those who came in early had a longer follow-up time. Those who came in like sort of midway had a shorter follow-up time. That's what it means. And then we had, of course, weekly. We followed them up for 1 week the first time because we wanted to make sure they're comfortable, they're using the method okay. And then we followed them up monthly, and they came back. As they came back to the clinics for routine visits, we were able to follow them up. And then we had an end of treatment survey and then interview for satisfaction, and then they returned the phone. People who didn't have their own phones had to return, so they kind of signed a contract that they're going to bring back the phones. This is hospital equipment, okay? It's just like we'll give you a blood pressure machine, you take it home, you use it, and when you're kind of fine, you bring it back. So that is how we described the phone, so that they didn't see it as any fancy technology that we are giving them. And I think our technology person also locked it so that they couldn't go to all the social media stuff, and for reasons that we can discuss later. So it was locked onto the app, and they were just using it to take videos specifically. This is not too clear, I think, from where you're from, but let me just highlight a few things, because this is just really the baseline characteristics of the 50 patients. So you can see how they fared, but I kind of zero in on where the phone stuff happens, right? So owning any cell phone, any type, was 96%, very consistent with what we had seen from the clinic-based feasibility study in 2016. So again, people reported that they had a phone, 96%. And then members with a phone, you can see that also kind of distributed very well between having no member, no other member, and then having 2 or more members in the household. And then smartphone ownership, as you can see, 70% had, so you can see it has already grown, right? Just from this sample, 70% had their own smartphone. And then the ones that we loaned smartphone that they used, because we kind of had to quality check. Of course, people have smartphones, but not all of them can carry apps, or they can say, oh, my phone is full. It's so full, I don't have space to add another app. So those were the issues that were going on there. So then we had about 58% with a loaned phone, a study phone, and then about 42, so 29 to 21. So here, I kind of show you some of the things that we measured at baseline. Again, just really access to TB services, concerns, what are the preferences that you have. Trying to understand the population that we are going to be able to implement this technology in the future. And so I highlight here mostly because of the transportation issues that we talk about as part of the barriers. So mostly, because this study was done in Rubaga, I should have mentioned, Rubaga division. And I know some of you might be wondering. So I kind of cut out the study setting, all the public that we usually talk about, but I wanted to go straight into the results. But it was done in Rubaga, so it's urban setting. And you can see by the transportation, about $1.6 really, round trip. So not too expensive, really an inexpensive, trip by and large. But mean time to reach the clinic, about 40 minutes. Of course, traffic jam, that is expected. And then mean time spent at the clinic, about 20 minutes. So these are patients who are coming to Rubaga clinic. So it's not a very heavily congested clinic, not the same as Mulago. So again, and then experiencing some difficulty with transportation. At least about 34% reported that they experienced some difficulty. So I don't slice and dice what difficulties, but it could have been, I had no transport, I had no one to bring me, or I had no means to come, kind of difficulty around transportation. And then the other thing that I learned, or that we learned, was the concerns. People still have concerns, and that is important because when you're rolling out a new approach, you want to understand what are the concerns, and does this method also bring the same concerns, or does it alleviate those concerns? So some of the concerns were about, so we asked about concerns regarding family finding out about TB status. So remember, stigma was one of the issues we talked about for DOT, for the in-person DOT. You can see, again, about 36% of individuals said, yeah, they were concerned, they were concerned about their family knowing about their TB status. And then about being concerned about friends, neighbors, schoolmates, people in their community really knowing about TB. 50%. So they really, at least they would rather have a family member know, but once it gets out in the community, it's like, I don't really want people to know. So again, those are the things that we are thinking about as we develop new methods that will deter people either to use or not to use. So here, I wanted to learn about the baseline experiences. So I'll just quickly walk through this panel, and I just pulled out some of the results, not everything. But this panel just shows how comfortable are you using a cell phone to receive calls. Obviously, we would expect most people to be very comfortable. So that's expected. Panel B says, how comfortable are you taking pictures with a cell phone? About the same, right? And then how comfortable are you texting? About the same, 70%. So that's really pretty consistent. Texting, receiving messages, taking pictures. But when it comes to taking videos, because that's where we're trying to delve into, we are trying to ask people to take videos, about 50% said they were comfortable. So half of our patient population was not comfortable taking videos. So what do you expect? How are you going to train them? This was information to help us understand. So this is what we collected at baseline. All right, so now this is the meat of kind of the findings, and this is how I summarize them again. Very simple, no p-values, no confidence intervals here. 50 patients, what can you do with that? I mean, it's a small sample size, so I didn't want to really go into the fancy statistics. But all to say is that the mean number of days under VDOT intervention was about 103 days, so about 3+ months, at least every person achieved that on average. So we were able to observe for some amount of time. Different from most of the other pilot studies, they were observing people really in the intensive phase or even for a shorter time, just to really establish, can people use this, can they go with it? But we had a good amount of follow-up time. And then we calculated the cumulative total videos we expected over the entire period of time we observed the 50 patients. And we expected about 5,000 videos in the system, 5,150. We received 4,200, which is about 82%. So, for what it is, I was really happy with this result, because I didn't know that people were going to send videos. I wasn't sure they would even work with what we were trying to tell them. But 80% of the videos we expected for the entire time of follow-up within the population, 50 of the patients, were sent. So what about, we calculated the median number of videos received per patient, and that's about 89. So 89, that means 50% of the patients at least were able to send that number of videos. And then median number of videos missed per patient, about 15. So about 50% patients missed at least 15 videos. And then here is what we kind of focus on as our main result, the median fraction of expected doses observed with VDOT. So what we coin as FIDO. So why is this kind of an interesting measure? Because people don't start at the same time. They're not enrolling everyone at the initiation of treatment. Some people are coming in on month 2, they only have 4 months. Others are coming in for 2 months, others are coming in for a shorter time. So when you do an average, you're kind of not capturing that, because the distribution by design is not uniform, it's not a normal distribution. So we go for this median fraction so that we are calculating on everyone's fraction of expected videos, how many did they actually send? So that is what this is telling us. And then here, the median total adherence. What I did was, once a patient said they did not send a video, the health provider or the research members of the research team picked up the phone and called them and said, but you didn't send a video, but did you take your medicine? So that is the self-reported aspect. And they'll say, yeah, I didn't have power, my battery was dead, or I didn't have airtime, or I didn't have, what do they call them? MBs. I didn't have MBs. So I took the medicine, but I didn't send a video. So for any reason, could be many, many other reasons. So we captured that, and we said, yeah, we are not going to discredit that as not taking medicine. And so that's what I add here as SAT, self-administered therapy. So when we add that, then the adherence actually comes to 93%, right? So here we're counting only what we observed with videos, but here we are adding to that total what people self-reported, of course. Give or take, I don't know what the error margin is, there might be some errors there, right? People can say, yes, I took a medicine, but so there's no way to kind of validate that, but for the most part, I would say when people say they're taking medicine, maybe they are. Okay, so that's the summary of what we found up to now, up to this point. So, of course, people usually like to say, maybe there are some differences by age, maybe there are some differences by sex, maybe there are some differences by location, so there's all many differences, many ways we can slice and dice the data. But I just give you the sex and age differences, and I really say, and I tested the significance in differences, but I don't even show the pre-values here. But there were, you can see there were slight differences. Over here, for age, for sex, male and female, almost similar median, almost a similar percentage fractions of expected doses. Not too many. If you look at the medians, a few outliers for females, for males, and a few outliers, one outlier for the female, but by and large, when you test the difference by statistics, it's not any different. When you look at the age, 18 to 24, the younger group, 25 to 34, and 35 plus, again, very, very slight differences. Again, not statistically different. So reasons for reporting or for missing videos, because that's another issue, because I think this is even more important than the actual result that I presented before. Why are people missing videos? How can we fix that? So the top reason that was reported predominantly was a phone malfunction. My phone died. It wouldn't work. So 32% of the missed videos were really given. So these are the number of patients reporting. So about 30 patients reported that their phone had died, it had a problem. Of course, many times you don't know what the problem is. You say my phone is not working well. So that was 32%. Phone battery died or not charged. Very common, of course. 38 people reported that, and that was accounted for 24% of the missed videos. And then you can see the list goes on and on, but again, I'm sure we can discuss almost each and every one of them and kind of try to find out. But it's important to kind of digest these reasons a little bit and begin to think what are the kind of things we are going to have to deal with if we are to make the video or the technology, the digital technology work. So these are the things that came up. So I show this all to make a point that we were able to collect some geolocation information. And remember, one of the barriers was all people can't travel to point X, they can't travel to the health provider, to the health facility. So we geo-mapped the location at which they were taking their medicines. So the smartphone is capturing geolocation. And so it's telling us if somebody's taking their medicines in Kasangati, or in Kamocha, or in any other place, so we're able to capture some of that information. So this is to show you that, so let's just look at one. So I think the orange one had some very interesting patterns. So you can see orange was taking medicines at one point over there, in another location, in Makindye someplace, and then took, so if they were to meet a health provider, they would really be in one place where they've agreed, right? But this is giving this patient the flexibility they need. So if you look at the brown person here, you see where they took their medicines 2 times, and then they go to Kalanga. This is Entebbe. I think there's one who went to Kalanga or somewhere. I don't show it in the map. But people are moving, but they are taking their videos and taking their medicines and going on with life. They are not tied to a place and a location. It's giving them the flexibility they need. So the point is, VDOT can overcome some of the geographical and spatial barriers. That's the point for this slide. And then I tried to map this to the nearest health facility. So Google Maps is able to pull up where the health facilities are. So this is the edge over there. So for example, if you were to go to this health facility, how close would they have been, or how far were they from the nearest health facility? Does that make sense? So at the end, you can really calculate distances, and I think Google Maps does that. You can calculate distance from where they would have actually traveled and begin to project some either cost savings, time savings, and all those things. You can go fancy with all this stuff. But this is just to show you how much kind of people are liberated to do what they need to do in different places. All right, so now this I think is my final slide, because this was the exit interview. To just really assess, we wanted to hear what patients were telling us. How did you find the method? How did you use it? Was it good? Did it give you satisfaction? And did I highlight anything? No, I was seeing whether I highlighted. But this really just tells you, 90% of the time, people are saying they were very satisfied. When you ask them about monitoring, specifically 92%, and then when we asked them about how they would compare in-person DOT and VDOT, 98% said VDOT is better than in-person. Others said, well, no, we didn't have anyone saying different, it's different, and then one person said they don't know. And then we asked, would you recommend VDOT to other patients? And of course, all of them said yes, we would. So that's, I think, the last slide. And then let me make some concluding remarks to tie back everything that we've talked about. So there are benefits to the health system from VDOT, as you have seen. There is objective and accurate measurement, because if somebody says they've taken their medicine, you see a video, you see objectively they are putting the pills in their mouth without having to be face-to-face with them. And you have all that data captured within a system that you can just download and analyze and report right away. Then it improves management of health information, because sometimes the paper records are flying everywhere. It's time to report. Everyone is trying to gather them very quickly and put them in one piece. It's not easy. It minimizes efforts on coordinating DOT visits, reduces transport costs or travel costs, less time away from routine work, so the workflow. It improves staff safety because there's less need to travel. Fewer self-administered doses, because the in-person DOT is supervised, I think, Monday to Friday, right? So they don't do weekends, at least as far as I know, and that could have changed. So you can correct me, I don't know. But I think it's, but for the video, they're recording their videos every day. So 7 days a week you can have a data point. Whereas for the in-person, you don't expect your staff to work over the Friday, over the Saturdays and Sundays to go watch patients taking medicine. And then of course it's resource savings. And this resource saving, we should think about it in a way that right now we're talking about the TB programs, and the leaders in TB are talking about differentiated care. So it's not like, completely let the health providers go and do other work. You're really saying that these resources can be focused or redirected to the people who actually need the care. Because the people who are moving and mobile and doing their own stuff, they probably don't need to spread the resources thin. You can now focus the few nurses or the few healthcare workers to focus on those people who really need it face-to-face. So that's the differentiated care. So that's a good way to redistribute the scarce resources. And so that's probably what would be the benefit. And then for patients, of course, they can take their medications when and where they desire. Greater patient autonomy, improved privacy, convenience, of course, anywhere, any place, and then the remote, removing the spatial barriers, and less travel time and cost for patients than in the clinic, and could increase the access to for the hard to reach. So on this point, because this is my last point, I'll tell you a story, because we learned two interesting stories. The two patients, one of them was leaving, I think he got a job in Dubai, and he was, I think, in his second month of treatment. So he came back to the clinic, told us, look, I'm not able to come to the clinic, but if you can help me talk to the nurses who gave me my entire supply of 4 months, the remaining 4 months, I'll be able to send you the videos. So off he went to Dubai. And for all the 4 months while he was in Dubai, he sent us his videos. And we can stand confident and say, this guy took his medicines. So if it was the in-person DOT, where would that patient end up? Lost to follow up, right? Isn't that the category? Yeah. Lost to follow up. And then we have so many headaches about lost to follow up. And this patient was able to give us data every single day, 7 days a week for 4 months. And he was in Dubai doing his work. Then another moved to Cape Town, and the same thing happened. He came, told us, and we have his information. That would have just been out of 50. So 2 out of 5, if somebody who knows math, what percentage would that be, lost to follow-up? What would be the 4%, right? What would that 2 out of 50 lost to follow-up? 4%. Yeah, so it's not a small number, 4% lost to follow-up, right? But the data is there. There could have been ways to capture that information. And so with that, I'll end by acknowledging my colleagues. Of course, this work is not done just singularly. It was funded by a seed grant from the University of Georgia. And then it's been very, very closely supported by my colleague, Dr. Esther Brugea from the School of Public Health. We have worked on this pilot. Thank you, Esther, for being such a huge support. And then Nina Tuyambe, Sarah Zarango, and then other colleagues from Richard and Kevin are one is from San Diego, University of San Diego, and Kevin is from University of Georgia. This is my research team who work tirelessly to call the patients, make sure they watch the videos and all those things. And with that, I want to thank you so much.